just mention some business meeting. There's a business meeting that I have scheduled, and I've given some dates, and I'd like all the members of the critical care subsection to try to come to forward their ideas. And I've actually chosen uh, 4 dates for the group to select, maybe two. So I've given dates of basically 5th and 6th September, Saturday, Sunday, and 12th and 13th September, Saturday, Sunday again. So any of those 4 days, 6 p.m., 7 p.m., for the business meeting of the critical care subsection, please send your preferences for those 4 dates to me. Give me 2 dates, and I will send them to the IM digital team because those dates are, the days, Saturdays will be popular, and there's 20 subsections, I think, have to do the meetings. So please let
Nehal,
me
can
know.
you display the flyer?
Display Professor Birinder's CV. You
Yes.
can do that now. Yeah, you can do that now. Let it be there. I'm waiting as we discussed, and Professor Birinder agreed to just delay his start by a few more minutes so that more people could come. So you could put up Professor Birinder's CV slide, which you prepared in the meantime for people to. I will introduce him just before he starts talking. Yeah, so that's one. So not that one. No, Birinder, yeah, Professor Birinder's, yeah, that's the one. That's the one. Thank you. Yeah, I think Dr. Srivatsan has also asked you to give the dates for the business meeting. We'd like the business meeting to be uh, well attended. So 5, 6 September or 12, 13 September, all Saturday, Sundays. Which of days you would like to the meeting to be held? Please let us know within, I think, by tomorrow midnight. So on 21st, I'll let Diane know which of those dates is the most popular. So that's the first thing. Now, these meetings, because of the IAN meeting in Jaipur, will there be a 2 month gap. So we won't be having a meeting that Sri and me organize on your behalf for the months of September and October. This is as per the IAN rules. We'll again restart in November and then try to do one every month. And I'd invite, so no meetings in September or October. November again, we start the cycle. So please express your interests to either Shri or to me or even on the WhatsApp group. And we will definitely accommodate all of you. So that's that. In the IN Jaipur meeting, it's perhaps desirable that we have a meeting, informal one, of the critical care subsection on the flanks. So nothing official because there may be some room restrictions, but in the last time in Kashi, after 6 p.m., we can meet for a cup of tea, as many of the critical care subsection members are, just to network and get to know each other by face and introduce each other in person. So I think those were the three business points I thought I would raise with you. So when do we need the business meeting? And the fact there is no meetings, but to start again in November, and I want every month something or the other to happen. And the Jaipur something meeting on the flanks between us to talk. I just wonder if Dr. Shri wants to say something. I know we're killing time a bit before we start. We start at 7:15 sharp. So, Dr. Shri, do you want to say something? He's our chairperson, Dr. Srivatsan. Dr. Shri possibly is dipped in, dipped out. So he's here actually. He left a message. So let me carry on a bit of my ramble. Well, Professor Birinder Singh Pal and Dr. Mehak Arora, we look forward to their presentation on a very niche topic. Now, I have been to Professor Birinder's hospital, PMCH in Ludhiana, and I really enjoyed the 2 weeks that they hosted me. I, on my travels, have traveled in many centers around the country, as something like a visiting faculty observer to learn and to network, to build up friendships, and to learn from other practices. So that's something that has made me, I feel, a very happier person. As Birinderji was saying today, that I've really learned from the younger generation quite a lot, their enthusiasm, their challenges as well. So I think that's what I would encourage many of you who are at the moment in your DM courses don't get time off, but when you finish, and perhaps you could do this, perhaps a week every year you take off and go to any other center, and that will build up the robustness of the Indian Academy of Neurology, networking, knowledge base, friendships, and make you feel happier, I think, that you know so many people and their practice environments. It gets your time like a visitor, like a tirtha, and just it's a neurology tirtha and not a religious tirtha. But you should do both perhaps when you're older like me. So yeah. So I think Birindaji, do you think I should start to introduce the topic? There's 23 of us here at the moment. Asmita I can see 23 number of people. Did the number roll? Shall I? Or do you have any other? I'll also invite questions and I'll be moderating. There'll be questions at the end of Professor Birinder's talk in the halfway house. So do keep putting questions in the chat box, and we'll take questions after Dr. Mehak Arora is presented and a grand question answer session. I would invite all the postgraduates to be very, you know, liberal, free in us putting the questions. Interactive session. This is not a very formal session, as you can see. It's meant to be teaching, student, teacher, guru, shishya type relationship where we learn from everybody, each other on the same level playing field. And no question is, simple enough. There's always something that we can learn. I see Dr. Srivatsan coming back. Srivatsan, Sri, do you want to say something before I formally start and hand over the presentation to Birinderji? Srivatsan, would you
Not
say something,
exactly, sir.
please? Yeah.
Anyway, yeah. Anyway, thank you, Dr. Birinder. You were my quiz master for one of the IN barbecue quizzes. So
Yes, yes, I
thank you so
remember.
much, sir.
Thank you, thank you.
Yeah, I was just doing my first year when I came in 2017. So
Mm,
anyway, nice meeting you, sir. And thank you for giving this wonderful topic because most of the times we use IVIG and plasmapheresis without exactly knowing where it's supposed to be used. So this, as Dr. Parthare had mentioned, this is a very niche topic and really glad that you had been kind enough to come and pitch in about this. So we'll start the session, sir.
right. Okay, right. So, as is always the case, I mean, everybody knows Birinderji, Professor Birinder Singh Paul from Glanand Medical College and Hospital in Ludhiana. I've been there myself. I've seen how hard they work and what excellent patient care I've seen, and I've had feedback from the patients. So, I've seen the clinical side. I've also attended a lot of their grand rounds and departmental journal clubs and teaching. It's a very active unit, and I've interacted with all the residents there, and they're very, very welcoming. A lot of people, and they learn quite a lot from Dr. Professor Birinder and his colleagues. So the CV, I thought I'd leave it up there for you to read. But he's a professor with more than 2 decades of experience. I think the achievements within 100 words, as it says out here, says a lot. And I'm actually particularly very much enthralled by his Sikh Personality Award of the Year in 2020. And of course, as Dr. Sri was mentioning about the neurology quizzes and the excellent contribution in the health and mental medical services during COVID by the Punjab Youth Development Board. Yeah, I think there's a lot of us who have other facets in our character outside of neurology, and we always try to improve that side of a persona because I think that makes a fulfilled person. Our job pressures, our research pressures always limit us to our subject, but there's always another flower in our hat which we also want to cherish and live for. So that's excellent. And of course, there are publications and chapters and books are there. So I don't think I should be standing anymore. We are nearly to 7:15. So I let Professor Birinder take over from now, and the next 2 hours or 90 minutes are definitely all yours and Dr. Mehab's to teach us, show us the way. Over to you, Professor Devinder and
Thank you,
Dr.
sir.
Neha.
First of all, I would like to thank the Indian Academy of Neurology, the president as well as the secretary, and also the chair of this subsection, Dr. Shrivan, for their kind words, and especially to you, sir, because you have given us this opportunity. We just mentioned that we want to present something, and you within a second, you said that you go ahead, just do that. Before I'll just have I we are my slides visible? Slides are visible.
Yes, sir.
Yes, we are
The
being
slides
visible.
are
So
Yeah.
visible.
just wanted to share one thing that this presentation remind us of with a close association with Professor UK Mishra, because we have the opportunity we holded one you can say neurocritical uh, conference during the COVID time on Zoom. And it was a so successful conference that everybody appreciated. We have faculty from outside also. Around 6 to 7 international faculty gave lectures, and also Dr. Mishra always gives this DMC a special opportunity to present their unique cases. So this was our background, and I would like to thank Dr. Parthare also, because of his encouragement we are able to present. And as rightly said, this is a topic for a neurologist. Sometimes we have so many, you can say, fear in our mind whether we use this plasma exchange. Is it a cumbersome procedure? Is it going to exactly help the patient or no? Or will my choice be a plasma exchange, IVIG, or something else? So with this background, we'll just try to simplify it. What we have learned, we have been using this plasma exchange almost, so you can say 15 years to 20 years. So we have gathered some of its experiences, and we would like to share our experiences, our publications, our, you can say, real world cases with your esteemed panelists, so that we can take your opinion also. And what we would like that this for 45 minutes to 60 minutes we'll try to answer what is actually plasma exchange is, though everybody knows that. What is the mechanism? Who may benefit the most? Is plasma or plex safe procedure? How does we can compare with IVIG? And almost we have seen that we resort this plasma exchange as a last resort. When nothing is working, we think that let us do the plasma exchange. Is it just, or we can just push it little more higher as a, you can say, after steroid, a first line before IVIG? Why isn't there are so much in spite of so much good in it, why it has not picked up? And what is the our take home message at the end of what we have learned? Are we confident enough to use in our clinical practice? So with this, just before that, we know that our understanding of the disease has been much improved with the availability of these electron microscope, new staining techniques, and also with the you can say of identification of auto antibodies or auto antibodies, which are there in most of our autoimmune neurology, what we call as a subsection. But you should understand the end result of these prospect or cascade is the complement activation, which will lead to inflammatory response. There is mismatch between the T helper cells, B cells, formation of immune complexes, and this results in this whole cascade of disorders which we see involving the intracellular receptors, extracellular receptors, membrane receptors, and so many things. And the identification of these auto antibodies is not ending. Every year we add up new finding a new antibody. Recently, I came across a paper in which they found that CD30 is a new antibody which can cause a non-compressive myelopathy. So this list is not ending. So this is there. If we are able to, for any management of the disease, we have to understand the pathophysiology, and if possible, we can tackle that pathophysiology. This will give us the best results. And it has been seen that this plasma exchange was first used in patients of multiple myeloma because to counteract the hyperviscosity. So almost you can say a decade has been passed in the use of this plasma exchange, and I have searched that almost 3 lakh procedures are being performed worldwide, and now this is an integral part of management in neuroimmunological disorders almost for almost a century. And it is a very fast acting, and it prevents the disability, yet it is underused. Why it is underused? Let us see, and what are our hindrances? Can our hindrances with the expert panel being discussed, we can get over these hindrances. So actually the principle of therapeutic plasma exchange is that where we effectively remove the abnormal circulating high molecular weight antibodies and other pathogenic factors which derive a autoimmune disease. And this is the most fastest acting immunomodulation for both the central as well as peripheral neurological disorders which are immune mediated or because of some, you can say, molecular mechanic mechanism is there. And it has been seen that plasma exchange still holds a cost effectiveness over the other immunotherapies. And although the use is also been increasing because of increasing burden of life threatening conditions, refractory myasthenia gravis, with a more and more autoimmune encephalitis which now almost comes in a differential diagnosis of all infectious etiologies of encephalitis. Plus, apart from that, there is significant improvement in the technology of the plasma exchange also. So if we see this is a busy slide, but it sees that around 1 to 1.5 liter, if we filter the plasma or we do plex, we are able to remove almost 60 to 70% of the pathological antibodies, as well as immune complexes, which are a driving force for continuing the process of, you can say, inflammation, resulting in persistent damage, persistent blockage of signal or cell death. So if we are able to do that, secondly, apart from that, the other thing the plasma exchange works, it stimulates the proliferation of B cells and the plasma cells. So what will happen? It will reduce the production of antibodies, but it will also improve the, restores the imbalance between the regulatory T cells and the B cells. So T cell regulatory helper cell will increase. So the suppression of more humoral response is suppressed. Also, it removes the large molecular weight substances. Also, it removes the cytokine, complementary, and anti-inflammatory other molecules which are continuing the cascade of inflammation. So that is why once you remove the inflammatory markers, you are able to achieve your result very early and also effectively. So although we think that plasma exchange is a very cumbersome procedure, you have to insert a, you can say, dialysis catheter in the vein. Either we do from the femoral vein or from the internal jugular vein. Then there it has two ports. In one port you have to one port takes the plasma, it goes into the machine. There is apheresis filter are there, it removes, and then it has to be resent back to the body, and during that we have to sometime replace with albumin also. Previously we were using ffp, but now albumin, and even the normal saline can be used to replace the fluid depending upon the premorbid condition of the, and there are few diagnostic workup which we have to do before we indulge in this process, like complete blood count, coagulation parameter, viral marker. Although this is being done in every type of immunosuppressive treatment, but it is not a cumbersome, it is the same process. Then during the plasma pheresis you have to monitor blood pressure for any citrate toxicity or any type of reaction, and you have to check the calcium levels. This is simple thing, and if you do one plasma exchange, you will become more confident and experienced, and you will not encounter any problem in doing that. So what is the advantage? Because it removes the complement and inflammatory substances, so it is the fastest acting immunomodulatory treatment which is available, and it starts working within hours of the first procedure itself. We have seen, we will share our experience also, that even in myasthenia gravis patient who are on ventilator on crisis, after the first cycle you can see that their ptosis has improved, their tidal volume has improved, the ventilator requirement has come down. Plus, the another important thing is that apart from the other immunosuppressive like cyclosporin, rituximab, although they are there in their place, but it does not cause the depletion of immune cell, or it causes the long-term immunocompromise. So why? Because it already also it improves the ratio of T helper cell to beta cell. So try to does not cause or does not disturb long-term our humoral or cell-mediated immunity, which gives an advantages. Because with this principle there are now when we were reviewing the literature, there are papers that people were offered plasma exchange even up to 2 years. Every weekly, every monthly, they were given the cycles of plasma exchange, like in CIDP disorders, myasthenia disorders, polymyositis, for even 2 years without any significant involvement or depletion of their immune system. Though there are certain logistic issues, financial issues are there, but the immune problem is not associated even with long term use of these procedures. So if we see the spectrum in the CNS disorders, there is class 1 indication, class 1B indication, 1C indication, but commonly it is being used for commonly like NMO spectrum disorders, MOGAD disorders, even previously in tumefactive MS, or those cases of multiple sclerosis not responding to or refractory to steroids, they have been offered this treatment. Although idiopathic transformalitis, autoimmune encephalitis, paraneoplastic syndrome, prions, sometimes CNS vasculitis, and even ADEM, which are not responding to the drug among the peripheral nervous system disorders, most commonly everybody is using for myasthenia gravis, Guillain-Barré syndrome. Then you have to think whether in which scenario you have to use IVIG or plasma exchange. Additionally, it can be offered to as a maintenance therapy or as a rescue therapy for CIDP. Recently, we have one lady who had CIDP, but she was not responding to IVIG. The duration of relapse was reducing. Initially, the relapse would occur after 3 months, but it occurred 1 month, 15 days, 7 days. In that, IVIG did not work. We put that patient on plasma exchange. We have done 4 cycles. Just finished last cycle 3 days back. We are waiting what would be the result. But she was weaned from the ventilator. She's off and shifted to the ward. And this, if we see the evidence as per the American Academy of Neurology as well as the American Society of Apheresis, the GBS, CIDP, and paraproteinemic neuropathy have a class 1 evidence of being offered to the persons who are suffering from this disorder. Similarly, if we see the apheresis, American Apheresis Society guideline, it is again a class 1 recommendation is there. But if we see myasthenia gravis acute or short term, it has been as class 3 in ANA, whereas in EFSA it is class 1B, whereas in LG1, Hashimoto, NMO, the evidence is gaining on. It is the evidence has been improved, but still it is in the apheresis group. It is in NMO, it is the class 2 or 1B recommendation as a quality of evidence for being offered plasma exchange to these set of patients. With this background, let us come first to the multiple sclerosis trial. There are, when I was reading, there were almost 7 to 8 randomized control trial were there, but they were old trials. I think by that time the rituximab, ocrelizumab, or other form of aggressive or high efficacy treatment was not available. So this was offered as a rescue therapy for those who were not responding to steroids or who have frequent relapse or who have tumefactive. If I look back into that literature, I think there will be some sort of patients because NMO came later on. So that might be possible that so-called tumefactive long segment myelitis not responding to steroid, they are actually the category of NMO disorder in which the plasma exchanges were offered and it was producing a good result. And in NMO disorder, there was 90 to 100% improvement with the maintenance and also during the exacerbation without reducing the relapse rate. And we were fortunate that in 2019 we published this our results very long back in those patients. These were our results of 5 patients in who were in 2018, you can say 8 years back, when almost I think 3 4 years down the lane it was found that NMO is a disorder which was separated from the among the list of demyelinating disorders, separate from the MS. And what we found, that we published this paper, and to see that this is a infographics in which we took They were, although the number is only five, but we took all those five patients who were not responding to either cyclophosphamide or steroids, and they had keep on worsening their symptoms and the disability so much that we have to offer them this therapeutic plasma exchange. And if we see, they were all were female in the range of 59, 36, 42, 55, and 58 years. And we performed, if we see, we applied the NMO criteria, all were NMO antibody positive, and the point of taking to plasma exchange were they were not responding to corticosteroid, or they are experiencing neurological worsening within 24 hours without any other, you can say, trigger factor like infection or acute medical condition. And if we see that in one of our patient we have used IVIG also, even cyclophosphamide also, and we started the plex at the day 30. Some people may contest that you have used IVIG, you will do the plex, the IVIG go, will the effect of IVIG will go. But we have waited for ample period of time, and number of plasma exchange which we were given were 4, and her EDS has improved from 8.5 to 4.6. The other patient, that is fourth and fifth, they have even used rituximab, and we have offered them the plasma exchange at 22 days and the other at the 12 days. So what we found, that there was 20% of them had almost marked improvement, that they were not disabled, they were able to walk independently, whereas 40% had moderate improvement, and only one patient which did not improve after even our plasma exchange, and it remained with the deficit. But what we can conclude at that time, we have offered them 24 cycles of plasma exchange with a mean session of 4.4, and 80% had overall improvement from mild to moderate. What we have seen in that, the improvement began after the second cycle. That means that it has removed the NMO antibodies. Apart from that, it also removed the immune complexes. It has taken care of the complementary factors, other inflammatory, and the other thing, that the all procedure were well tolerated, and no adverse effect were observed. So what was conclusion, that it can be safe and effective treatment in 2018, which we concluded, and it will lead to marked improvement in steroid affected cases. So it should be preferred as a rescue modality, or when steroids are ineffective or other immunomodulatory treatment fail. The other thing which we found, that rather than being a rescue therapy, if we are able to commence it earlier, because in some of the patient we have started early, although number is very small to comment, but we found that earlier the commencement is there, better will be your clinical outcome, because you are removing these inflammatory immune complexes, heavy molecules, before they could actually damage the cell membrane, or they could actually damage the neurons or myelin sheath. So apart from that, it also, we have seen that it was very cost effective, and it should be, we suggested that it should be used in the future. So with this, and but now we come to other autoimmune disorders, although the evidence is 1C, 2C, and we come across now with the Casper syndrome, NMDA. These are all disorders which have significant impact and disability associated with disorders, because by the time we are able to diagnose them, we have already in the stage of second or third, they have crossed that stage on, and cell damage or cognitive problem, movement disorder, seizures have been started, and the now the catastrophic will be there, and the course become very fast. So what, and if we see the evidence, they have 1 2b 1b evidence is there, and the literature suggests that plasma exchange across these autoimmune disorders is a viable first line of defense is there, but most of the time it has been used as a last resort. But from our experience, whatever we have done in all these patients, what we found, the results will be better if a person is a younger one. There is a shorter duration of disease from the onset to the start of this treatment, and it is provided in those who have ongoing clinical worsening is there, so they are the ones which will more likely to improve. And also it depends upon your experience, your backup, also the case scenarios, your case selection, because these are real world patients, and sometimes you burnt your fingers also. So before that, let us share few of our patients who had this autoimmune. This was an 18-year-old girl who presented with memory impairment followed by abnormal sensorium is there. Once we see that, we know that it is an autoimmune encephalitis. NAMDA was there. She was started on IVIG methylprednisolone, but her sensorium did not improve. And on MRI, we found that there was a ovarian teratoma. So unless we remove that teratoma, she will not going to get improved. So what we did a bridge plex therapy, and this teratoma was removed, and she was almost, you can say, so she has improved. So this Plex has given us the bridge therapy of removing that teratoma, giving us, although we know that they respond to rituximab, but the effect of rituximab will come after 2 or 3 weeks. But we needed to have an urgent and immediate fast response, so we relied on this. Second, it was a 22-year-old female which had a movement disorder. This was the MRI. Methyl did not work. Plasma exchange worked, and also although she improved, but the disability was there, she was able to stand with support, and gradually she's improved. This was a unique patient, although this patient had plex in PGI, but this patient, just you can say, presented to us with a confusional behavior and these type of abnormal movements, which we called as a coriform movement. This was the clue. She was diagnosed as a case of functional movement disorder, started on treatment, not responded. Somebody thought that these white matter changes are ADEM, so she was given steroids. She did not improve. She landed to us for a consultation, and when we examined that her, we found that something is wrong. Probably this is a striatal encephalitis. So we start looking at the secondary cause for that. That is probably the paraneoplastic syndrome. So what we found that on PET scanning, there was a lymph node in the supraclavicular area, as well as there was a lung lesion. So then we biopsied that, and it was found that it is a non-small cell carcinoma of the lung. Because of her cognitive decline, she was not responding. For financial reasons, she went to the PGI for the treatment, and then we published this case because this was a very rare finding of paraneoplastic striatal encephalitis secondary to non cell carcinoma of the lung, which responded again to our plex. So this is our series. We have just sent it for the publication, that these are the 5 cases of long segment transverse myelitis which were double negative both for NMO as well as MOG. They have received steroids, but these are patients who were not responding, and their MRS was 4. And what we done, we have given them the plasma exchange as a therapeutic option. 4 to 5 cycle were given over 10 days, and the MRS in all of them improved to 2. Plus, we found that in similar to our NMO results, it is a cost-effective, safe, and if properly performed in a selected patients, and we have a good experienced blood bank with us, which do plasma exchange for us, and they are very good. We have to just tell them, we have a policy, that protocol, that all these plasma exchange will be done in a stroke ICU or neurology ICU under the supervision of a resident as well as blood bank resident, so that in case of any something happening, going wrong, something is done, we could pick up early and so as to treat them. So should we think that it should be considered more frequently in these immune mediated disorders, because they sometimes are very disabling and they do not reverse. So coming to our peripheral nervous system disorders, which include Guillain-Barré syndrome, then remitting and relapsing CIDP variant, myasthenia gravis variant, paraproteinemic polyneuropathy, and multifocal neuropathy. So tell you, we know that myasthenia gravis, we know the antibody, just like NMO. It is an antibody-driven method, and we know if we see the pathogenesis, the antibodies are formed. These antibodies then cross-react with the post-synaptic receptors, causing them blockade. Also, these antibody or immune complexes also generate the complement. Complement is generated, which leads to increased activation of formation of complement in there, which indirectly cause inflammation. So there is one physical blockage of the receptors, second immune complex destroying, complement activation, B cell infiltration, T cell infiltration is there, so receptors are gone. So what happens? So we know that the mechanism is that if we remove that antibodies along with complement inflammatory substance, we are able to achieve a good results in myasthenia. And there have been head-to-head trials were also there comparing IVIG and therapeutic plasma. They were found that they were both effective and with comparable efficacy. Though in our practice, what we have been taught in AIMS New Delhi, that our protocol is not to use high dose steroids in replacing this IVIG or plasma exchange. Specifically, in MuSK cases, you have limited, you can say, effect of IVIG, and therapeutic plasma exchange is the recommended modality of treatment because it removes the MuSK antibodies. They are very large antibodies, large molecular weight antibody. So only way to remove with them is the therapeutic plasma exchange, and also it forms immune complexes which will be removed. Plus, it has been, there are papers in which plasma exchange has been used monthly or two monthly for almost 18 months to 2 years for almost five or six patients. There was a paper of five or six patients in which it was giving these patients, putting them into a remission, and they were pharmacologically also, they were remission in their treatment part. Plus, it can be offered as a periodic plasma exchange, but we have to understand, if you want to give a periodic change, we have to think of where it to put the cannula, because you cannot put the cannula in the femoral or internal jugular vein and send the patient home for and come call back for their product. There are different protocols in those who want to, in where you want to give a monthly plasma exchange protocol. It was first done in 1979. So you can say that way back. And Davis was the first who performed in seven patients and reported a almost complete recovery of all patients of myasthenia. Since then, there were five randomized trials, and all these trials, randomized trials were there, which was showing 80% to 100% improvement. And the median time for improvement was almost 13 days to 4 weeks. So such a shortened, so the reason for this shortened improvement or recovery time may be that we have removed that molecular antibodies which were responsible for the disease. And we were happy to share that we, in from our institute, we have published a paper on almost 35 patients of myasthenia gravis, either not responding to myasthenic to the first line treatment, or they are in myasthenic crisis with age of almost 18 to 62 years, with mean age of onset is 32 years, and their classification of myasthenia is 4A in 12 cases and 4B in the 5 cases. So you can see that these all cases are comparatively sick cases, difficult to treat cases, and among them 23 were on mechanical ventilation when we performed the plasma exchange. So you can see that we think that plasma exchange is a very cumbersome process, but no, even on patient on ventilator we are performing plasma exchange. So it might be possible that it is not so cumbersome what it looks, but once you start doing it, you become, it is a routine part. And only 12 were non-ventilated patients out of 23. 23 these indication were, they were bulbar palsy, motor dysfunction, and they were in crisis. Whereas in 12 there is a progressive exacerbation is there, not responding to the usual treatment of steroid, cyclophosphamide. When we published this paper, there are very few centers which were using rituximab. We were not using rituximab during that time when we published this paper. And overall, we have done 41 cycles of plasma exchange with 175 sessions with a 4.2 session per cycle. Mean volume we removed ranges from 2 liters to 5 liters depending upon the body weight, and the duration of these exchange were ranging from 200 minutes. 180 to 200 minutes, almost you can say 3 hours to 3.5 hours. And if and all these patients were already receiving either azathioprine, immunosuppressive treatment, prednisolone, and they all these patients showed a good functional outcome. And if we see what we have even seen from patient perspective, only we could see only 9.4% of anaphylactic reaction in each cycle, which is non-significant, and they responded just to injection hydrocortisone. Citrate toxicity was seen in only 6.8%, which is manageable. Plus little bit of catheter issue, catheter get blocked, or we have to reset the machine, seen in 4.6%. Hypotension was seen only in 1%. As a neurologist, we are very fearful regarding the hypotension, but it was not there. And the outcome was there. No infection was recorded in all the sessions in all the patients, and there was no therapeutic plasma exchange related death were there. 74.2 reported that it has a good acceptance for their management. And if we see the outcome, three of our patients they died because the death was not related to plasma exchange, rather they probably improved only mild to moderate, and they succumbed to their age, also to their chest infections. Whereas almost you can say that six patients have complete remission. Complete remission means there is stoppage of even their drugs. Four patients, that is 10 of them, they were almost pharmacologically remission was there, and seven were on minimal dose of the immunosuppressive or cholinesterase enzyme drugs, and subsequently we are able to taper them within 6 months to 1 year. So you can see almost 70 to 8% were there, and at discharge 10 patients at the time of hospital discharge were of free of their pharmacological treatment, so resulting in meaningful reduction of their you can say disease. So what we concluded that it improved short-term outcome because we have given for one time only, and there are certain disorders like autoimmune encephalitis disorder or in case of GBS which are one-time insult. They will not going to keep on occurring again like CIDP or myasthenia gravis. So in that set of site in one time or like ADEM, we are able to achieve good results because this is a one-time thing. You do it and patient comes get out of their disability. And for those in crisis or during their exacerbations, they are refractory to steroids, or this is an option to be offered. It is a safe, well tolerated with good acceptance of almost 74.2% with no death attributable to this process. If we also analyze the cost effectiveness, at that time our cycle cost just 12,000 rupees. Compared to IVIG, it was equally and comparatively effective but cheaper, and so it might be relevant in our resource limited countries or countries or hospitals, though we have a charitable hospital, but still it is IVIG now cost almost 2 lakhs to 3 lakhs at present. So it is an primary treatment option for myasthenic crisis. Specifically, this was our conclusion from the study, given a comparable efficacy and low cost relative to IVIG. So other like GBS we also do, but now almost 90 to 80% people are using IVIG. And it if we want to offer therapeutic plasma exchange, it should be offered within 4 weeks ideally, but still within 2 weeks. But the corticosteroids after or before there are no randomized trial. Only it is contraindicated if there is lot of hemodynamic instability, or you think that because of autonomic dysfunction you are not able to control the heart rate or the blood pressure. And yeah, there are few fears that IVIG, if you give IVIG, then plasma exchange, the IVIG will go and the effect will not come. No, this is not the true. There is a recent paper in which they found this is a super IVIG. What do? You give IVIG, no response, then do a therapeutic plasma exchange. And if there is a response, but the response is less, you can repeat a half dose of IVIG again. But at the same time, you have to understand it will increase the cost also. In CIDP, we just discussed one of our patient not responding to IVIG, not responding to rituximab, steroids, mycophenolate, azathioprine. We have offered them a plasma exchange. We have done 4 cycles. We have taken her off the ventilator. She's going home. She has gone home today, so we will see the result. But we have given 4 cycles of plasma exchange. It has been seen that in those subparanodopathy, that is IgG neurophysin 151, therapeutic plasma exchange is the modality of treatment, because these set of patients they don't respond to IVIG, though they respond to rituximab. But if you want to get a faster result, you because rituximab will take time to act, so plasma exchange can be offered to them. And there were 8 randomized trials comparing the efficacy of both IVIG, and they were found that to be equally effective. So we just start with one of our, again sharing one of our patient, which was a very you can say difficult decision making and treat managing patients. So this was a 58-year-old gentleman who came to us with a flaccid quadriplegia with respiratory failure requiring mechanical ventilation. So he was admitted outside in a hospital where he was given as usually IVIG. The moment the IVIG was given, 10 ml to 25 ml of IVIG has gone in, he had a cardiac arrest. So, being in the hospital, being on the ventilator, they revived that patient and he was without any, you can say, hypoxic damage. The patient was revived, but still quadriplegic, requiring mechanical support. So, thinking to be either IVIG induced uh, something wrong, or there is a autonomic dysfunction, because both when we received this patient, we have both this in our mind. So what next step would we do? In that, we have a discussion along with the relatives, even with our team also, that we should we offer them IVIG or should we offer them plasma exchange. So our team suggested that let us go with IVIG again, but now this will be IVIG will be given from our hospital. We are more sure about the cold chain, we are more sure about the quality, and plus we think that it was the autonomic dysfunction which has led to cardiac arrest, not the IVIG. So we gave IVIG. But once we started on IVIG, again he had a cardiac arrest. We revived that and he went into hypotension. So again we gradually built up this person. Then again he had persistent hypotension. So what was the step? The family said to us, "Do something, please do something." So what we done? We went ahead with the plasma exchange now. But because we were fearful that during the plasma exchange there will be hypotension, so we prophylactically started this patient on inotropic support. This patient had, instead of 5 cycles, what we have done, we have rather than removing the recommended 200 ml to 250 ml, we done it 75%. We done it under, and we have given, instead of 5 cycles, six cycles. With this, every time when we give the cycle, we give start the inotropic stop. So, for our surprise, after the 4 cycle, he was weaned from the ventilator. By the 6th cycle, he was off ventilator, he was sitting, and now when he follows in the OPD, this 58-year-old gentleman is MRS of 0. That is, he's walking independently without any problem. So, this where we can share this Plex comes to our rescue. So safety profile, transient hypotension was there. This is our safety data. All the plex we have done, we have seen some central line problems are there. We agree with that. This is seen in 25%. One thrombosis we have seen. Catheter issues are there, albumin getting down. You have to build up these patients. You have to take care of citrate toxicity. But all these side effects are manageable. They are not life-threatening. They will not stop your procedure. They will not let the patient down because of these side effects. We have seen, but they are manageable. Sharing one more patient to you. Every time the results are not so successful, what we aim at, this is the paper, this is a case which we published just to tell you that this was a 22-year-old male who has a body weight of 130 kg. He presented to us with the diagnosis of Guillain-Barré syndrome because of the financial concern. Relatives said that the cost because of his weight, or even if we apply a corrected weight for IVIG, if we remove the overweight part, then also they were not able to bear that cost. So they requested us to go ahead with the plasma exchange. This was the case which was published in 2015. You can well imagine that we are doing plasma exchange almost 15 years to 20 years down the lane. So we went ahead with plasma exchange. When this, we have given 1 cycle, he was fine. We have given 2nd cycle, he was fine. That is, there was no deterioration. Rather, his the graph of deterioration which is going down was stopped. By the 3rd cycle, when 3rd cycle we finished, next morning what we found that he's having some respiratory difficulty. We were worried why he's having respiratory difficulty in spite of being on mechanical ventilation. So we got the ABG done of that patient. We got the echocardiography of that patient. Echocardiography was normal, and the ABG was not was rather showing that there is a carbon dioxide retention. So we checked our ventilator circuits, that something wrong with the ventilator circuit. No, it was fine. So we were thinking this, we have even written down in this our paper that in next 24 hours, this patient had a, you can say, tachycardia and hypertension. Plus, we thought that it could be possible that this patient is having pulmonary embolism because of plasma exchange which we did from the femoral line. Why he's not showing the signs? Because there was associated Guillain-Barré syndrome. So Guillain-Barré syndrome causes type 2 respiratory failure, whereas pulmonary embolism causes type 1 respiratory. So the picture got mixed up. So we took that patient directly to the cath lab. So where we did, because this patient, we don't have the time to get the CT angiography, we took the patient directly to the cath lab because he had a cardiac arrest right in the ICU. So we took that patient, we found that both the pulmonary arteries were blocked. So went ahead. We went ahead with the mechanical thrombectomy and mechanical thrombolysis of with urokinase, as well as mechanical thrombectomy of one of the right pulmonary artery, and we were able to save that patient. So for our surprise, once he's out of that pulmonary embolism complication, after 5 or 7 days, he was able to walk. So even 3 cycles of plasma exchange made some difference, and now we are following that patient almost 10 years. He didn't follow to us. Last we have seen in 2019, he was walking about and normal. So we even have burnt our fingers, but still we are able to, even in spite of this complication, we are able to salvage that patient, and still he is free of disability. This was a patient which we initially started plasma exchange 1 cycle, but we deferred because this is again a case of long segment myelitis. But at the second cycle, we found that he's having hypotension and respiratory difficulty. So when then we realized that he had associated deep vein thrombosis, which was causing pulmonary embolism, small there. So in that patient, we deferred that procedure. So even we have faced a complications, we have faced problem while doing it, but we have not still not stopped using that. So what we did, we sent that patient across. Then the other center, he was managed first with DVT, then plasma exchange was offered. So we think that still it is underutilized because of easy availability of IVIG, easy availability of other plasma, or you can say immunosuppressive treatment. That may be the reason that this is underutilized, or not all center have that lucky enough to have good blood bank, good support of doing plasma exchange. Sometimes vascular challenges are there. We think it is an emergency procedure. Even lack of therapeutic, we question the lack of therapeutic, you can say, accountability of plasma exchange in improving that. But we think that now the time has come. I am thankful that we have given this opportunity, that from rescue therapy, let it be a evidence-based precision medicine for managing these complicated so-called refractory patients, where we can offer them plasma exchange. So this was a nice article which was published in BMC Neurology, which looks after the clinical and economic outcomes of therapeutic plasma exchange versus the IVIG for treating adult patient with autoimmune neurological disorders, and it is a systematic review as well as a meta-analysis. What they found, that they concluded the effectiveness and safety of this exchange was comparable to IVIG for treating these autoimmune neurological disorders. It conveys a lower overall healthcare cost than the IVIG. So this even endorsed by a person or by a paper which is, you can say, from a high income countries. They also think that this is the benefit of plasma exchange. So what are the practical consideration for incorporating these plex in our clinical practice? That it is a immunomodulated treatment that does not cause immunosuppression. Neurological autoimmune disorders you should consider early in the course, not in last resort. Utilizing even for acute and longer treatment could avoid undertreating these patients, and sometimes they give good results. Replacement fluid can be 5% albumin, or it also spares your blood product exposure also, because now you can replace only with albumin. It also spare your cost and also the exposure of blood products. Plus, sometime medicine can be removed during this procedure. We have to understand that, but we can always replace them. Only caveat is that avoid LP or any invasive procedure with at least 24 hours before and after, because you are giving anticoagulation. Also, there is a chance of some citrate toxicity is there, and it is better that it can be handled with just oral calcium. We give oral calcium 500 milligram tablet 2 times a day during this procedure. And if it's, do you think it is a citrate toxicity, you can give even IV calcium also. So it is a, you can say, customizable, personalized, safe, effective, and cost effective modality of treatment, specifically with the increasing number of identification of autoantibodies, autoimmune encephalitis, and so many diseases. Now with the guidelines in place, you are able to make the diagnosis of these autoimmune disorders, even antibody negative, prior on very fast. So I think if you are making a diagnosis very fast, so patients should also be given the opportunity of getting their best treatment, because this plex will cause the direct removal of your, the pathogenesis, target the it target directly the pathogenetic part of the disease, and it removes these inflammatory complement and large molecules. So it will, at the same time, it will stop the ongoing damage which is occurring. And we have seen that, like in LGBS, CIDP, once a membrane is damaged, it will take a time to repair or recover, and that time will add to the disability part, and also will increase the duration of hospital stay, cost of treatment, mechanical ventilation cost, hidden complications like infections. So if we are able to cut down, and we can have, we have seen in our paper also, otherwise also, that even myasthenic patients, we just discussed, on the, even on mechanical ventilation, you do plasma exchange, by the time next morning you will see they are opening their eyes, their tidal volumes are better, they are lifting their hands and feet. So that's all. Thank you again. Thank you for the subsection for giving this opportunity and gracing us to present our work and our experiences. Thank you very much. I'll stop sharing, sir.
Thank
Thank you
you,
so much, sir.
Rajiv. That was great. Absolutely spellbound.
Thank you, sir.
Yes, I was taking notes as well as you were speaking. That was actually tour de force, as we call it, of the entire plasma exchange, immune modulatory disorders. I get and I thank you very much for showing that meta-analysis of the comparison between IVIG and plasma exchange and the clear cost benefits. I think it's the lack of awareness and the physician's mindset that has come in the way in the judicious and optimum and certainly increasing use of plasma exchange in the indicated conditions compared to IVIG. And dare I say, there has been some pharmacological industry push towards, I think, across the board, across the globe, in promoting IVIG usage over plasma exchange to the state exchequer or the personal payers' financial constraints. And we've all been victims of it, I think. But I think we should be ruled by the science and the evidence. And that's very important. And thanks for highlighting all of that. Uh, we'll take questions. I'm waiting for Dr. Mehak Arora's slide to come up online.
Just wanted to make a comment, sir. I
Yes, sir.
think
Please
the,
do. It's
it is
interactive. Yeah, please do.
it is the ease of a physician. We think that we start the IVIG, we'll just ask the sister to do the IVIG part, and
Yes,
we are,
yes, yes.
we can sit in the OPD, we can do other work, we can see patients, and also for the relative, it is a very simple procedure to do that. I We
Mm,
agree that that is the norm that you have to do, but sometimes we have to move out of our comfort zone. We have to take
absolutely.
strict decisions. We have to individualize our decisions. We have to,
Yeah,
even in today's world, what we have done, sir, we are able to do so much of work in plasma exchange only with the support of our team, also discussing with the all the relatives and all, even with the patient, that these are the pros and cons. If you explain them, they do agree. In We have shown that in our practice, we have seen 4 or 5 patients only which demanded only plasma exchange, but rest we have to convince them. But before we convince them, we have to convince ourselves that this is a safe modality. if we can use it. And I think there is one paper which said that it was underutilized, and I have highlighted
Absolutely.
few of the reasons why it was
Yeah.
underutilized, because the other thing is very easy to give. Just wanted to share one more, if you allow, sir.
Please
We
do. Oh, no, no,
recently
no. You got time. Yeah, go on.
so we recently, Mehak will remember, we have one patient, sir. We think that it was a case of probably dumb rabies or a rabies-induced quadriplegia. So we were thought, but rabies were negative, but we were contesting between. We offered them, she came to us with upper limb weakness, and within 5, 6 days, she went into the bed-bound state that she has quadriplegia. So we happily offered them the IVIG. No, you give IVIG, will take care of that. For our surprise, you cannot imagine, sir. After the second dose, she went into cardiac failure. She have EF of only 10%. We were scared that it has caused, probably we think that it has caused MI. So we were scared and we shifted that patient to the cardiac center. You have seen our Hero Heart Center. I
I've seen it. Yes.
Whenever I have such problem, I see the patient every day. When they did the echocardiography, they thought that it was only 20%. But I
Oh,
told them, probably we think that probably this is will be idiosyncratic reaction. It could be a Takotsubo cardiomyopathy. Please do the
yes.
angiography. So they have done that angiography in that patient. The angiography was perfectly normal. So you should understand that IVIG is not without problems.
Oh,
That
yeah, yeah.
that case then turned out to be Takotsubo cardiomyopathy. And after
Really?
2 weeks, we repeated the echocardiography. The echocardiography
Mhm.
improved, but because of hypotension, low cardiac output, we could not do the plasma exchange. But that patient is still wheelchair bound. That has not improved, although life is saved, upper limb are improved, but still she was not able to get what she wanted. So even we have
Regarding, yeah,
burnt the
yeah.
fingers with the that was the my second case where I have seen myocardial infections. We have seen subendocardial infarction after IVIG, but that was the my second case where we could pick because we have the proof of angiography, coronary angiography, which was normal. So this was a Takotsubo cardiomyopathy which occurred secondary to IVIG. Just wanted to
Yeah.
share.
No, no, no. That's very important. I mean, I was going making points basically. I mean, I've seen you in action, and you're a very active faculty on the ICU that you have, which is huge. Actually, I think 26 beds or something like that you have
So now
at your
we have
latest
14
facility.
beds. 14 beds.
Oh, your commit got down. Okay, okay. So it's gone down. So I saw you at your peak of activity and rushing around here and there. So that's important. I think the cost factor of 2 lakhs versus 12,000 is actually a no-brainer, particularly when there's evidence that is possibly equipoise or maybe favoring on health economics, the plasma exchange. I think my limitation in plasma exchange is having to ring up the blood transfusion team, them getting the machine down, limitations of machines. How many do you have? If there's, I think, two or three
Sir,
people requiring
but
plasma exchange.
the advantage in our hospital is that there is a very active liver transplant program is there.
Yeah,
So
yeah,
liver people are doing plasma exchange 2 or 3 every day. Now we
yeah,
have 5 or 6 machines, and
absolutely.
they are very
And
small and compact, portable. They can be
very
shifted.
much so, yes. They were huge in
No,
1994 when I
it is
first
just
saw
like
this
you can
medication.
say, I can
Now
tell
they're
you
very
just like an inverter,
handheld type things. Yes, absolutely. They're very, very small and it's very regulated. It's all punch in the codes, punch in the data, and the machine does all the calculations. And it's all very seamless, as with technology, So if it's suitable for the patient, then so it should be. It's a human product as well, IVIG. So we must reserve human product for the most needing cases. So I think there's an indication. I was looking up any IAN guidelines. Maybe we should have some guidelines as such
So
on the
that
plasma
was the issue
exchange.
to do that, so that in our IonCon also we can have lectures regarding the plasma exchange.
Yes,
In this, even if you because in your subsection you can plan and lecture for 15 minutes only to
yeah,
increase the awareness of use of these disorders. Even
absolutely.
Lex is there for autoimmune disorders, no movement disorders
Yes,
also. But nahin, this is
Yes.
a set of in neurocritical care we can plan, we can push and get 15 minutes so that more and more people get involved. Although we think that is a domain of blood bank, but no, our resident Mahak is very experienced in doing plasma exchange
Yes.
and handling the complication. Because whenever complication occur, blood bank people don't help us. It is we
Yes.
have to take a decision. It is sometimes
Absolutely.
we showed in our case, we have done 6 exchanges instead of
Yes.
5. And we
Yes.
sometimes skip a day so that patient could get relaxed. And what we have done to further reduce the cost of that, sir, what we done, we do a plasma exchange in the ICU, we shift the patient back to the ward. So we save 1 day cost. Next, we do a cycle 1 day after, and again we shift it back. So that also reduces the cost of continuous staying in the ICU, unless the patient is on ventilator, like in our myasthenic series. But in NMO
Yes.
series, ADAM series, log series, है ना? So we have done
Uh-huh.
in OPD also.
Yeah.
In indoor, shifting again and back to.
Yeah. Yeah.
Dr.
You did
Birinder,
mention.
just three
Yes.
questions.
Go on.
If
Yes,
you
sir.
don't mind, can I ask them, sir?
Yes, sir. Yes, sir.
Yeah, of course you can. Of
About
course. Yeah.
the
Please go on.
feasibility of maintenance plasmapheresis. So, have you
Yes.
done that, sir, so far?
No, sir. I have just read it. We were planning to
Okay.
do in 1 hour patient. What we found logistic problems are there. If you want to do a plasma exchange for let us say weekly for 1 month,
Hmm.
3 months, you have to put in a arterial line or permacath because
Yes.
Yes.
you cannot keep the jugular vein or
Central line. Hmm.
you cannot keep for more than 1 month or you have to replace. So what the series suggests, because we are now planning in that patient which we discussed that don't respond to IVIG, we will offer them weekly plasma exchange because there are paper of weekly plasma exchange. But in that, just like you can say in chemotherapy, you have to put a permacath or you have to put a tunnel of subcutaneous tunnel where you put that catheter directly into your main line. So, and you have to tunnel that catheter. In that set of scenario, you can offer them. But at present, sir, we have not experienced in that.
Okay, so the second question is plasmapheresis before thymectomy in a patient with myasthenia. Do
Yes,
you routinely do or you have any criteria, sir?
sir, we usually in our series there was no patient who was planned for thymectomy. We have done plasma exchange who were either going into crisis or mechanical ventilation. But yes, there are papers and we have not done. But you can do plasma exchange before thymectomy if the patients what are the criteria if the patient you think is not on a stable dose and thymectomy is required because of underlying CA or it is causing because few of our patients have invasion of the you can say aorta or there is invasion of the other local parts so where you have to do the urgent surgery otherwise you think that disease will spread or patient is not responding you can go ahead with a plasma exchange in those who have gone high dose of steroids one or secondly you think that you need a faster period of recovery where you have to subject to thymectomy in a recent time like 15 days or 3 weeks and also patient has received IVIG it has not worked and there is a flaw we have even discussed with there are few of the people who came from outside which were expert in plasma exchange they said that this is not the problem that IVIG you give then do plasma exchange IVIG will be removed. This is usually not seen except only few percentage of IVIG is being removed rest it is in the body itself and in the other centers what they are doing I inquired in PGI also that if you think that the patient is very sick you can even give half dose of IVIG after plasma exchange to have both combined benefit. This is called super IVIG treatment what they call in PGI.
Exactly, sir. So this is something which we are also recently working on. And contrary to traditional belief that giving IVAG and doing plasmapheresis will remove the IVAG, in fact, they are saying that when we give IVAG and do a plasmapheresis, the
Yes.
IVAG is going to bind to the pathological antibody, and the
Yes.
plasmapheresis will selectively remove these
Ah,
antigen complexes.
yes, Bill, definitely. So that is why it will give
Exactly.
other help. Yes,
Mm. So this is the concept of the super IVAG, where we
super
are
IVIG.
seeing
Yes.
a extremely wonderful effect.
Oh,
So
good.
this is one thing which I wanted to ask you, sir. And the third and final question I have is for GBS, do you make a rule that it is only 5 sessions, or you think if there is a clinical indication, we can go beyond 5, say 7 or 8 sessions?
So in we shared one of our case in which we have done
Yes,
sessions
I
because of
wanted you to highlight this topic for so that our people can understand that, sir.
So in that case, sometimes you have to break the protocol or you have to go beyond protocol. So in that case, we have to first, whenever in our practice, what is first principle is no harm to the patient. If you think that patient is little bit dicey, there you think you can do or you can give plasma exchange over 6 cycles. There is no harm in doing that. You have to sometimes don't remove almost what is recommended at 200 to 250 ml. You can go up to 175 ml to 200 ml. Do it in 6 cycles. You will get the results. And delaying for 2 days, that extending the plasma exchange for 2 days will give you benefit and no harm. There is no harm.
Exactly, sir. And one last thing, leave the concept of super IVIG. Some centers, what they do is beyond the fourth cycle of plasmapheresis, they give a very low dose of IVIG, something like 0.5 gram per kg, saying that it will replenish the depleted antibodies. Do you subscribe to this idea or have you used this in any of your patients, sir?
So this is my personal view. This is my
Hmm.
personal thinking that I think that will not work because that will only add to the
Yes,
cost. The what if plasma exchange by 4 cycle, you will be clear whether it is working or not. If it is working, you have to be
exactly.
patient. I just share that case of CIDP. Na, that lady
Hmm.
told that Doc Sahab, you have done 4 cycle, there is no improvement. I just told her to wait because we have seen result even once you finish the plasma exchange, even after 4 days of plasma exchange, you get the result just like in our
Exactly.
patient which who had pulmonary embolism. We have given her a 2.5 cycle only, and he improved. So you have to be patient. But I disagree with this concept that you give half a dose.
Hmm.
I don't. It is my way of looking at the things.
Wonderful, sir.
Right. Yeah. Yeah.
Thank you so much. And you had cleared a lot of what I would call as controversies or enigmas around the concepts of plasmapheresis. Thank you so much, sir. I think
Thank
we have
you.
a question in the chat. I would also uh, raise that here. How many days after IVIG is it ideal to do plasma exchange if needed?
If you see the literature, ideally up to 24 days you can do plasma exchange. Best if do is 14 days. Suppose let us take an example that a patient comes on day one, day two of his illness. He's quadriplegic by day two. You start on IVIG. If you have started on the IVIG, I would suggest to wait for at least 14 days. 14 days for the IVIG to show the effect. If 14 days you think there are certain parameters that his respiratory tidal volume is going down, what we have seen sometimes the facial muscles are not involved, but patient on IVIG we have seen even on IVIG the facial muscles are gone. You have bilateral facial nerve palsy. There are soft indicators that the disease is still progressing. Then I think by 7 to 14 days you can plan plasma exchange, but not
Yes,
immediately
sir.
second day, third day of completing the IVIG.
Mhm.
I would like to wait for minimum 14 days, what I personally think.
Yes, sir. So to summarize, we should wait for at least 10 to 14 days
Yes.
before
Yes.
initiating plasmapheresis if an IVIG dose has already been given.
Please remember that you have given a adequate dose, you have not underdosed that. First, you have to see that also.
Exactly, sir.
Right. Okay. Thank you very much for those very,
Thank you.
very informative and very intriguing questions. And thank you for sensitizing all of us to plasma exchange on evidence base, Professor Berinder. And thanks to Sri for asking those very searching questions. There was a basic science slide, Professor Berinder, on
Yes.
the T helper 1 and 2 cell subpopulations that
Yes.
increase
Uh,
when one does plasma exchange.
Yes, sir.
I
This is
didn't
very,
quite
very interesting
follow
finding,
that.
sir. Because they
Yes.
said that because of autoimmune disorders, your basic imbalance between TH1, TH2, B cells are disturbed. So once you do a plasma exchange, there is some immunomodulation. This imbalance is also corrected. One more thing I want to highlight that what we have realized during the plasma exchange that sometimes when you do the first cycle, na, there is worsening of thing is there. Why? Because once you do the plasma exchange, you are removing the antibodies and complexes. So this will indirectly stimulate the B cell. So during that period, so after first cycle, you get worsening. Don't worry about worsening. If you want to tackle, give little bit of steroids because B cell population will initially go up because there is a rebound increase. Just like in what happens, we call when we give steroid, there is a worsening because it will tackle the infection. So don't worry. if this happens, but ultimately with repeated cycles, your TH cell will be, although we have not checked them in a scientific way, but literature show they are improved, so they will curtail the production of antibodies more. They will they will tackle the B cells. So TH also increases. Yes, this is there.
I have a feedback comment from a Dr. Radhakrishna Hari. He says, I do plasmapheresis before thymectomy only if the in myasthenia gravis means if the acetylcholine receptor antibodies levels are very high. Dr. Radhakrishna, you can come online and speak and ask Dr. Professor Berinda the question. What did you mean by that? He says, you can see it Berinda as well. He says, I do plasmapheresis before thymectomy only if the antibody levels are high.
So that means what if you wanted a result to be done, because they will remove directly the antibodies. If they are high, then there will be chances that they will respond very well to plasma exchange, just like Musk, because Musk antibodies are large molecular weight, so they don't respond to IVIG. And you think that thymectomy is a must because it is an invasive carcinoma, it is a rather than myoma, it is a carcinoma. Then you can go ahead. Yes, he definitely he's right. Then you can plan.
Right. I think we have spent a very good 1 hour with Professor Birinder highlighting the plasma exchange. And the only request I can make is that why doesn't Professor Birinder consider doing some guidelines for plasma exchange in neuroimmunological disorders
So
on behalf of the Indian
so
Academy of
you
Neurology?
form it. We can plan that. We can do that. You just
So you write up the guidelines and then you submit it to the subcommittee, and then we will
hey,
publish it
you
as part of
with the
because
permission of the chair also we
yes,
can do that.
yeah, I think you would
We
be
can
the
get a
perfect position with Mehakji with a practical
Definitely,
experience
sir.
to do
We'll
the
push it for a
guidelines.
statement paper.
uh,
We can
so
definitely
Absolutely,
do that. We'll work
because
on that, sir.
yeah, yeah.
so
The
we
American
just
Academy has it, EFNS has it, even the Association of British
we can
Neurologists had it
include
for 20
we,
years. So we
sir,
should do
sir,
our own.
we can include the blood bank people also. That is
Yeah,
those who
absolutely,
have
yeah.
done their
I
blood
invited them
transfusion,
to that.
MD blood
Absolutely.
transfusions. We can include them and form a group of around 5 or 7 people, three
Yeah,
from our side, three from their side, and we can,
absolutely.
with the permission of chair, and even chair can lead us. So we can do that. I have so many contact with the blood bank people
Absolutely.
also. They can
Mhm.
also tell us from PGI, from our institute, and one from the
You
other.
lead.
If
You lead.
no,
Well, I think we could
let the
have
chair
something
lead.
good for the country coming out of all this.
Let
Yeah,
the
because
chair
we've done
lead.
so
We
much
will
work.
let the
Yes,
chair
yes,
lead. We will be there. We are equally part of that. No problem.
absolutely. Yeah, so I think
We'll
that
definitely
something
work
good
it
for
out,
the
sir.
country will come out of the
And
plasma
we can
exchange in
have
neurological
in future,
conditions.
if you want, we can have these type of short sessions of untouched area in the critical care,
Absolutely.
neurocritical care. And these are the
Absolutely. I'm open for
untouched
it.
areas.
Absolutely. Right. I think we'll keep more questions for the end because
Okay, sir.
I'm quite mindful that our colleague Dr. Mehak is waiting on the flanks, and I'll request Asmita ji and Snehal ji to please put Dr. Arora's CV on PPT on the screen, and she has agreed to present herself and her CV herself. So it's a new one, and I want instead of me presenting her, she would like to self-present. So, Dr. Mehak, are you ready to
Yes,
talk a
sir.
little bit about yourself, about your work, about your thesis, about your interests? So, yeah, I won't stand between you and the audience. Please take over. Take 5 minutes to
Thank you
talk
so
about
much,
your
sir.
CV. It's a new one.
Yeah.
Go on.
Good evening to everybody, to all the esteemed faculty and my dear colleagues. I'm Dr. Mehak Arora. I am pursuing my DM Neurology residency as a third year resident now in DMCH Ludhiana. And I've done my MD medicine from the same college. So DMC has been a great part of my journey as a doctor. My DM thesis, as we can see, was on somatic comorbidities in older people with epilepsy. The chief interest I've developed over these 2.5 to 3 years is actually epilepsy, owing to my mentor, Dr. Gagandeep and Dr. Virinder. I have done some research work in epilepsy as well. That included my thesis. I've written a book that chapter co-authored with Gagandeep sir on epilepsy in older people as well. And there was a publication on a case report of a rare ring 20 mosaicism in Journal of Epilepsy Research. So, but more than these academic opportunities and all the papers and the books, book chapters that I've written, it's more about the experiences and the people in these 3 years who have shaped the way I approach any patient. So that is much more valuable and much more of something that I look up to. And one thing residency has taught me is that we can never know everything about everything actually, but more so in neurology. So every discussion, every tough patient, every interaction with Barinder sir, every senior teaches us something, and it leaves a mark. So to my juniors, that is what we should always be after. We should always strive for knowing more. We should always be not be afraid of asking questions and be humble enough to learn always, because it's a long and enduring journey in neurology. So on that note, I'd like to start the session. This is a should I share my screen, ma'am?
Yes, Dr. Arora, thank you very much. We prepared this small presentation, this PPT, as Professor Birinder was giving his lecture, and I'm so grateful that Dr. Arora chose to speak from her heart and give some reflections to all of us as to how we could, look after each other better than what we have ever done before. And great
Thank you so much, sir.
acknowledgement to Professor Gagandeep and Professor Birinder for having looked after the education and the pastoral care of all of you so very well. So thank you very much, Dr. Meha Karura. Please now start your academic discourse. We'll all
Sure,
listen.
sure, sir.
Thank
Sure,
you.
sir.
Over to you.
Thank you so much for the opportunity, sir. I'll just
Thank
share
you.
my screen now. Just a second.
It's all right. Please take your time. There's no rush. We're all here to learn, so learning at easy pace.
महक
Very
स्क्रीन शेयर हो रही है तुम्हारे को आया ऑप्शन
Yes, sir. Yes, sir. एक मिनट बस.
कोई बात नहीं, आप टाइम लीजिए ना. यदि असुविधा हो तो मुझे भेज दीजिए पीपीटी. मैं अस्मिता जी और स्नेहा जी को बोलूंगा, आपके लिए ड्राइव करेगा. आप बोल सकते हैं जितना सुविधा हो.
No, sir, I was able to share it before also. Yeah, I think I will be able to share it now.
हाँ, अभी आ रहा है.
Is the screen visible, sir?
हाँ हाँ, लेकिन स्लाइड व्यू में कर दीजिए. हाँ, अभी ठीक है.
Yeah.
ठीक है, शुरू कीजिए.
Right, sir. So now we are going to discuss an interesting case. A young male presenting to us with recurrent strokes, all restricted to the posterior circulation. So the enigma actually started in November 2024, when this 35-year-old previously healthy gentleman with no conventional vascular risk factors presented with a holocranial headache, which was associated with vomiting, which was immediately followed by a transient global amnesia state for approximately 1 day, where he could not make new memories, retain new memories, but his consciousness was preserved as per the attendance, and his sense of personality was preserved. There were no other focal neurological deficits apart from the fact that he could not remember anything that happened the previous day. There's no history of any seizures, head or neck trauma, any intoxication prior to this, and no prior such episodes were noted. Since he got all right the next day, so they did not seek much of medical attention at that point in time. But 1 month later, he developed another acute neurological event. Now he had sudden onset vertigo, slurred speech, ataxia, no historical pointers pointing towards vertebral artery dissection. On examination, he had dysarthria, gait ataxia, cerebellar signs were positive on the right side, power and planters were fine. So, given the hyperacuity of this presentation and the previous episode, we kept a possibility of this being a vascular event. This one affecting the right cerebellar lobe predominantly, and the previous one must have affected the hippocampus. So that is what our MRI proved. This was done about 4 days later than the episode that he had. So this MRI showed bilateral cerebellar infarcts, mainly in the right cerebellar hemisphere. This is the right SCA, superior cerebellar artery territory. But we can see that there were areas of diffusion restriction on the in the second, so in the left cerebellar hemisphere as well, extending on to involve the superior cerebellar peduncle. Then this right posterior cerebral artery stroke as well. So in the same MRI, we also could see that there was evidence of the flare hyperintensity in the right hippocampal region that could localize the previous event that happened 1 month ago. Also, there were diffusion restriction in the left PCA territory, in the left paramedian thalamic perforator branches, that is the left pulvinar. And the anterior circulation seemed unremarkable. So at this point in time, a plethora of possibilities was kept. Since this was posterior circulation, vertebral artery dissection in a young male was obviously sort of, but given the knowledge that we had bilateral superior cerebellar artery involvement and bilateral PCA territory involvement, this is slightly odd for just vertebral artery dissection to present like that. RCVS was a good possibility. The patient had headache both times, and it was followed by recurrent neurological events within 1 month of the first episode. And then inflammatory and infectious vasculitis was high on charts because this was recurrent multifocal ischemic events in a young patient with no prior vascular comorbidities. Other possibilities of cardiomyolism, prothrombotic state were also kept in mind. With that in mind, we started the etiological workup. The cardiac screen was normal. We went ahead and did the other tests as well. The routine labs of note, ESR and CRP were absolutely within normal limits. HbA1c was fine. His lipid profile was deranged. Apart from that, the routine investigations did not reveal much. Even his autoimmune profile was negative. Here we were looking for secondary vasculitis. It was all negative. The ANCA profile was negative. Serum ACE levels were normal. Then the hypercoagulability workup, protein C, S, and the antithrombin 3, they were all in normal ranges. APLA panel was negative. Serum homocysteine was also normal. So we could not find a secondary cause. Keeping a possibility of infectious vasculitis, we also did a CSF analysis in him. The opening pressure was normal, and the patient had slight pleocytosis with lymphocyte predominance and slightly raised microproteins as well. And VZV PCR or TB PCR were all negative. We obviously went ahead with the angiograms. The patient actually presented to us after a workup from outside. We had MR angio and CT angio written reports from outside. Unfortunately, we didn't have the images. The CT angio depicted that there was luminal irregularity with beaded appearance of P1 and P2 segment of the right PCA, as well as P2 segment of the left PCA, and distal attenuation of the further cortical branches of PCA territory. So what we did at our center was DSA, which is obviously the hallmark and the diagnosis of choice to look for vasculitis, though not the gold standard. So these, we are viewing the DSA images now. We can see in the first image, these are the two vertebral arteries. I'm hoping that my pointer is visible. These are the two vertebral arteries which are mingling to form the basilar artery, which is ending as the two posterior cerebral arteries. The penultimate branches, both the superior cerebellar arteries, can be seen here. The red arrows are telling us that there was an abrupt cutoff in both the superior cerebellar arteries. In the second figure, we can also see that the distal P2 segments were attenuated, both on the right and the left side, but more so on the left side as compared to right. Right side, we can still see some branches going off, but on the left side, the distal P2 is actually attenuated and there's no filling beyond this point. Similarly, we can also see that there was the caliber of the vessels was decreasing as the distal branches were ongoing and is severely attenuated at the red arrow point. Also, the purple arrow is pointing at the superior cerebellar artery, where there is a filling defect. There's a attenuation of this vessel. Surprisingly, we found another thing. This is right vertebral artery. The V2 segment had this fusiform dilatation. So with these DSA findings, we kept primary angiitis of CNS as our first possibility, primarily because the alternatives were not identified. There was no secondary cause identified even after extensive workup. The patient had multifocal ischemia in bilateral PCA and superior cerebellar artery territories, and it was varying ages of infarcts. And the angiographic evidence was quite sufficient to enable us to diagnose primary angiitis of CNS. The patient was quite preserved at the time. He's a young male, so biopsy is not something that they preferred to do, although it was discussed with them. So this is a probable PACNS diagnosis and not a definitive one. As per this 2009 review by Birnbaum and Hellman, our patient fits into the probable PACNS category. In the absence of tissue confirmation, but there is high probability of findings on cerebral angiogram together with abnormal findings on MRI and a CSF profile, which is consistent with an inflammatory pathology. So we went ahead and actually started him on steroids, which was followed by an oral taper, and steroids was stopped in about 6 to 7 months. And he was also started on immunosuppressants in the form of mycophenolate sodium at a dose of 500 mg twice a day with single antiplatelet statin. During the 18 months that he was on immunosuppression, he had no repeat events, no headaches, no further neurological episodes, independent functional status. So keeping that in mind, after 18 months of continuation, in April 2026, MMF was actually stopped. But within 35 days of stopping MMF and discontinuation of immunosuppression, the patient presented to us with another neurological event. This time he had headache followed by slurred speech, mild right-sided weakness and clumsiness of the right hand. Examination revealed human facial weakness and right ataxic hemiparesis. This was an outside MRI. The event occurred on 6th of June 2026. We can see there were bilateral paramedian thalamic infarcts, as well as an infarct in the caudothalamic groove. This is probably the reason for his ataxic hemiparesis. Given that we have had the previous history and we knew that the PCA and its branches were attenuated, this all could be contributed by the thalamic perforator branches, which are probably attenuated and leading to this reinfarction. Oh, sorry. So we went ahead and did another DSA at this time. This was 8th of June. We could see that the fusiform ectasia of the V2 segment of the vertebral artery was still present and slightly more in diameter. Earlier it was 4 by 10. This was 5.5 by 10. Also in the 3D view, we can see that the thalamic perforators were attenuated as per our hypothesis on the MRI. We can also see that there is persistent attenuation of the P2 segments of bilateral PCA branches on the right as well as on the left side. So the findings of attenuation, segmental narrowing was still persistent and actually probably more than before. But of note is that the earlier DSAs told us that the superior cerebellar arteries were having an abrupt cutoff, but this time the superior cerebellar arteries were well seen. This here is the PCOM on the right side. We can see that there is segmental dilatation followed by narrowing, again supporting our diagnosis of vasculitis. We can also see on the 3D anogram here on the right side that the ICA origin was also attenuated. Now, to further characterize the vessel wall, because DSA is a luminal scan, we also wanted to have a look up at the vessel wall imaging. This time we went ahead and did the vessel wall imaging to further characterize and confirm that we are on the right track of treating this case as a primary angiitis of CNS pathology. So we can see on the right side, this is V2 segment. On the right side, on T1 and T2, we can see there is vessel wall thickening with T1 post contrast enhancement. This is a concentric enhancement, although asymmetrical, but this is concentric, not eccentric as we would expect in a atherosclerotic case. So this goes with our diagnosis of CNS vasculitis. Here we can see the basilar artery and the arterial wall were all normal. The ICAs were also fine. ICA bifurcation was also fine. This is a coronal T1 post contrast image, again telling us that the V2 segment of the right vertebral artery, which was showing fusiform ectasia in the DSA, has this contrast enhancement in the wall, and which is a concentric contrast enhancement. So after this stroke on June 6th, the patient was restarted on MMF and oral steroids. His ataxic hemiparesis was partially recovering when within 20 days of this first event, he had another episode, which was worse than the first one. Now he had right hemiplegia with dysarthria and facial weakness. This was the initial CT done outside, which just showed the old infarcts, the previous right cerebellar infarct and the recent caudothalamic groove infarct and the paramedian thalamic infarct. This time the new findings were again the left PCA territory showing some diffusion restriction, but this was the etiology of his major clinical presentation, the left parapontine infarct. This is a basilar perforator infarct. So summarizing, our patient had the starting of his symptoms in November 2024 when there was headache, vomiting, and transient global amnesia, followed in 1 month by another multifocal infarcts in bilateral cerebellum, bilateral mesial temporal lobes confining to the bilateral PCA and SCA territories. And then for 1.5 years, there was clinical remission because we started him on immunosuppression and steroids. And then within a month or so of stopping immunosuppression, he redeveloped a stroke, which was actually worse in intensity than before. And within 20 days of the first stroke, he developed another stroke whilst being on immunosuppression. So due to paucity of evidence of any other etiology, we were still thinking this to be a primary meningitis of CNS only, although it is well known that PACNS will involve anterior circulation more commonly, and there's no reason why primary meningitis of CNS will just involve the posterior circulation only, and multiple times, 4 times over the past 4 years. The patient was given IV methylprednisolone pulse this time, and he was started on cyclophosphamide. He has recently received a third dose. Rehabilitation ongoing, and his power is definitely improved. Although it has just been 1.5 months, we did repeat a DSA just 3-4 days back, which still shows the similar kind of findings. The fusiform ectasia is still there. The P2 attenuation, as we can see, is still there. And the distal P2 branches, segmental narrowing is all there. There is not much resolution in the DSA findings. So our therapeutic dilemma is that why the disease is now behaving so aggressively. This is a young male whose entire clinical presentation has been confined to recurrent posterior circulation disease only. There are similar findings on DSA also. There is lack of any cerebral microhemorrhages on the scans, which is very characteristic of PACNS. This time, during presentation, the patient did not have any headache. Although the initial response to steroids and MMF was quite good, but the relapse was soon after MMF withdrawal. It suggests that there was persistent disease activity rather than a self-limited vasculopathy. And we're not sure that MMF was working well enough. Is it just a chance effect that patient had a stroke after stopping MMF, or there was true causal relationship there? And then there was rapid recurrence despite reinitiation of MMF as well. So the question remains that is this simply a severe or relapsing form of PACNS, or does the rapid progression despite immunosuppression suggest an alternative vasculopathy? Yes, PACNS still fits because although restricted to posterior circulation, it is very typical of PACNS to involve all sized arteries. We could see in our DSA findings large artery, that is vertebral artery, then medium sized arteries, that is the SCA and PCA, and then the small arteries that are the distal PCA branches, all were involved and in different stages and different ages, which is peculiar for PACNS. Then there is persistent multifocal arterial narrowing rather than a transient angiographic abnormality like RCVS would do. So that favors PACNS again. And then there was a concentric enhancement around the vertebral artery, the involved fusiform ectasia, the area where the ectasia was. So there was a vessel wall abnormality and a concentric kind of enhancement, which again favors our diagnosis. And there was an initial response to corticosteroid and MMF as well. And we have not been able to delineate any secondary etiology either. So we continue treatment on the lines of PACNS. Although other differentials do pop up in mind, especially the non-inflammatory arteriopathy, which can lead to similar presentation of fusiform V2 abnormality and arterial beading. But intracranial posterior circulation involvement and recurrent infarction is much less typical for FMD or other non-inflammatory arteriopathies than inflammatory vasculopathies. Could this still be RCVS? So there is current absence of headache and there is persistent abnormalities over years and relapse peculiarly after MMF withdrawal, which favor PACNS over RCVS. And then atherosclerotic disease was not very evident on our angiographic pattern. Infectious vasculitis had been ruled out earlier only by doing a CSF, and the changes won't persist for 1.5 to 2 years like that. And other non-inflammatory or genetic arteriopathies were also probably less likely. So if this is PACNS, the next question that comes into mind is how long should immunotherapy now be continued? The patient has received 3 doses so far with persistent angiographic abnormalities. Yes, the angiographic abnormalities are not expected to go off so soon. And we should actually probably repeat vessel wall imaging at 3 months of giving immunotherapy to look for any changes and to look for improvement. So is there justification for continuing the induction until no further clinical events and radiological stability, or we should just follow the conventional guidelines and give cyclophosphamide for 6 cycles and then shift to oral therapy? There's no evidence-based fixed duration specifically for PACNS which favors either over the other one. So that is the question that still remains uncertain. Should the treatment duration be guided by disease activity rather than an arbitrary number of cyclophosphamide doses that we conventionally follow? And when should we start with the maintenance therapy? Should we start it after clinical and radiological stabilization rather than simply after completing a predetermined number of cyclophosphamide doses? So that is the question that still remains. And with that open question, I conclude my case presentation, and the question is open for the esteemed faculty in the panel to share their insights on. Thank you so much.
Yeah, thank you, Dr. Arora. Very intriguing, and thank you very much for a wonderful analytical, very cerebral analysis of your cases. Very good working up. There was a slide which you showed and then you didn't show. It was about the mimics of the various different.
Yes, sir.
You want to bring it up again? I had a
Sure,
fleeting
sure.
glimpse of it.
Sure, sir. I
I
will.
think that was on the vessel wall imaging and all the various different mimics that can. I want to take a picture of it with your permission, if I may.
Sure,
Yeah,
sir.
that's the one. Yeah. I think that's quite a, I've seen it somewhere, I forget where, but I had a brief glance at it. Yeah.
So
Well,
this slide is showing, yeah, the mimics of
it's
vasculitis
very
on
short. Yeah.
vessel volume MRI.
Yeah. It's a very good one. I think it's very good analysis. Right. Okay. So thank you very much for a very good analysis, raising uncertainties. So this is a patient of
Thank you,
Professor
sir.
Birinder, is that right?
Yes, sir.
Yeah. So maybe Professor Birinder wants to highlight a little bit more, and then Dr. Sri, myself, and I'm sure the audience would like to come in and contribute. Please do. Audience, I'm sure there are some senior members and, of course, other DM residents who I would like to hear as to what they. It's an open-ended diagnosis, isn't it? Certainly for me, the CSF was quite active, 14 cells, all limbs. I didn't quite remember the protein and the glucose count. Were they all normal?
Glucose was normal and proteins were mildly raised, 80.
Right. And the other thing was the marked predominance. Well, it is entirely posterior circulation, and you talked us and totally sparing the anterior circulation now. Primary angiitis nervous system completely sparing the interior. And there isn't much of a indication to do any invasive procedure like a meningeal biopsy now that the patient is better. Is that what you were saying? So there's no indication for the risk-benefit ratio to pursue the diagnosis further invasively, pathologically. That's the question.
Yeah. So the biopsy would definitely be a better choice here, but the family was not very. They were given a choice of biopsy, but they were already very apprehensive with the strokes that
Absolutely.
were recurring, so they were not very willing for the same.
I wouldn't have it done myself if I was the patient because is the patient getting better overall, isn't it? The the
Right now, he
cyclophosphamide,
is. Yes.
yeah. So listen, harm anybody who is getting better from whatever the
Yeah.
diag. But we don't have a correct diagnosis. Is that the main dilemma we have out here?
Yes, sir.
So the working diagnosis PA, CNS, that's the best fit, as it were.
Yes, sir. Yes, sir.
Any other immunological markers could help us in this aspect, or biopsy from any other more accessible tissues could help us. Lungs completely clean, high resolution. It's entirely
Yeah.
primary CNS, nothing else vascular. You had some
Nothing else.
neurological
Yes, sir.
markers that were
So
negative. Yeah,
yes, sir. So these were all checked once outside also and once at our center also,
you gave us
and
the detail.
we did not find any secondary etiologies here.
Yeah, I think you have done much better than I could have done. So I'll hand over to Professor Berinder now and ask him to, elaborate on the case, and
Thank you.
Sri and other members in the present audience, please.
Thank you, sir. I think Mehak has done a very wonderful
Very
job.
good job.
As
Yes.
she was the one who pursue all these investigations, because once we for in 2024 when we saw the patient, we thought it is a simple case. There is a simple vasculitis, but the contrary to that, usually CNS vasculitis is disease of older age group, not a younger age group. We extensively searched, we could not find anything. And if we see literature, even 2 years down the lane, disease still confined to CNS, not systemic, then it practically rules out that this is not a systemic cause of vasculitis. Probably it is the oscillator. When he had a second stroke, it was even a nightmare for us because he's a young boy who is working, and suddenly whole families he's gone. His memory is gone. He's hemiplegic. His vision was lost. He had homonomosynopia. So we thought that now there is a lot of pressure on you. You think you made a mistake of starting the mycophenolate, but as the guidelines show, they say that if you are in a remission for more than 1 year with no disease activity, nothing of that sort, no headaches, no, you can just stop it. So even we stopped at 2 years, then he had a stroke. So we started the medication, but again he had a stroke. Now this was a so disabling stroke. Then we get together, we discuss with our Dr. Mahak was there and other people were there, because we think that although we started the mycophenolate, but it will take 1.5 to 2 months for its effect to come on. So at that time, we took a decision right in the beginning that in spite of being a so disabling and pontine infarct, we will go ahead with steroid pulse. First, moment we started steroid pulse, you cannot imagine his power improved dramatically. His vision improved dramatically, his speech improved dramatically. He was on Riles tube was out. So then we thought that now we have to treat this disease very aggressively. It might be possible he will not respond to mycophenolate now. So we again took a step in the same visit. We after steroid pulse finished, we discussed with the parents. The parents were very understanding, although they were apprehensive. We went ahead with cyclophosphamide. The moment we gave cyclophosphamide, his other disability also improved. As she has rightly pointed out, now only disabilities with the weakness part. His memory has improved, his vision has improved, his even speech has improved, his rise tube is out. Now even he insisted that he want to join the duty back. But we thought that let us now this there are few questions that she has rightly raised, that should we give the 6 cycle of cyclophosphamide 1? Secondly, again, we start on mycophenolate or azathioprine? We are not sure, but I think one of the drug we have to do now, we have to give for 2 years or 5 years. Very difficult to answer because we have to see the long-term consequences of immunosuppression also. One, but still, what we wanted this panel to give us some of the answers to help us in framing our decision regarding the management part now. I think we have done amply with the diagnostic part. We have almost worked up, we have done MR imaging, DSA has been done. The biopsy, according to me, will not give her the result because MRI contrast were not showing any meningeal enhancement. To get a biopsy of the vertebral artery, and that too sometimes it may be a very risky thing, although intravascular biopsies are being planned all over the world, but it is not done at our center, and I think it will not give us the result because we may get something non-specific inflammation at high risk. So we will not be adding anything more to our diagnostic armamentarium except it is some sort of vasculopathy. If it is infective, it would have not been there for almost 2 years and no systemic features. So what we thought that we should continue cyclophosphamide for almost 4 to 6 cycles, then we may overlap with mycophenolate, what we planned in this case. But we are open for any comments. We are open for any suggestions to take so that we can better manage this patient. This is what I wanted to add. Dr. Partha, you are on mute.
Yeah, I'm waiting for Sri to
Okay.
add to the discussion, and for anybody
That
else in
was
the
a really
audience to
wonderful
please
case
kindly
and
go forward.
yes, sir. So that
Yeah,
was
we
a
can hear
really
you.
wonderful
Carry on.
case, and I'm pretty sure almost all the neurologists have at least one or two cases like this, where we are exhausting almost all our resources in reaching the diagnosis. You know it's a vasculitis, but you don't get any direct evidence, and the patient improves with immunosuppression. Even I had a patient exactly like this, except that it was a recurrent occipital bleed. We had even considered possibility of amyloid vasculitis. We got the staining done. We even went an extra effort in getting a biopsy done. But then the patient doesn't give an answer by any of these modalities, and then they respond very well to immunosuppression. So, sir, you are 100% justified in the treatment given, and I don't think any other investigation is going to add any information beyond this. Probably in the future, we might identify a biomarker which can confirm us this. We are having a lot of biomarkers in the field of dementia, in the field of movement disorder, in the field of epilepsy. So probably we might get a biomarker in the field of CNS vasculitis. We might be finding new antigens. But as you mentioned, this is not an infective vasculopathy. It cannot run around for 2 years. And doing a biopsy is not going to give any extra information in the face of a patient who's responding very well with immunosuppression.
Virendra, two questions have come up from the
So I read
audience.
them. One is regarding
Yes,
the
right.
IVIG part. I think he responded to methylprednisolone, so we don't give IVIG. Rather, we would like to add a immunosuppressive agent in this. That is why we don't consider IVIG. And if you read, IVIG itself can cause hypercoagulability. So he had a stroke. So we think that it is, and if we read CNS vasculitis, they respond better to steroid, cyclophosphamide, and less to rituximab also, because these disorders are usually cell mediated. And if you think humoral disorders respond to rituximab, because this is a CD20 B cell inhibitors. So these, in our practice, we use cyclophosphamide very oftenly, and we think when cell-mediated immunity is there or T cell disorders are there, in that set of scenarios, cyclophosphamide always, according to us, score better than rituximab, which target the B cell disorders. So we think it is a T cell disorder because that is why he was responding to mycophenolate. So we don't consider the, but you are right, we can think out, but in this case, we don't think it is probably to give IVIG in this patient.
Yeah.
In fact, there is a paper, sir, we'll try to share it, where they have mentioned IVIG can be counterproductive in
Yes,
CNS
yes,
vasculitis because of
yes,
the two mechanisms you mentioned. And the third mechanism is one of the side effects of IVIG is also an aseptic meningitis.
yes,
Most
yes,
people who receive IVIG have a headache, so they believe that in fact it can breach the blood-brain barrier and increase the T cell mediated immunity, induce
yes.
the damage in the brain further. So we are 100% justified in not giving IVIG.
We see, but in our practice now, 10 gram IVIG is available. What we are seeing that by the fifth dose, almost 90% start complaining of severe headache and aseptic meningitis features. That responds to naproxen or paracetamol, but we are now seeing that aseptic more frequently. When we were using 5 gram, we were not seeing that, but 10 gram we are using more, seeing more that. And you are absolutely right, I
10% high concentration IVIG you are referring to,
think.
Hizentra. Yeah. I see Professor Sunil Gajre raising the possibility of azathioprine. Did you want to unmute yourself and come online and ask the question, Professor Gajre? Sunil Gajre has raised the possibility of azathioprine being used. So do you want to, Asmita ji, would you want to promote Sunil Gajre ji to camera and then he can ask the question and discuss? Yes, please.
Hello.
Professor Gajre can come online and discuss the case as well. He has put forward the suggestion of azathioprine there. Professor Sunil Gajre, do you want to ask the question to Professor Berinder directly online on camera, please? Just set query azathioprine in this case.
So if you want, I can answer that. Azathioprine
Yes,
will
please do. Yeah. In the meantime, for time, yeah. Please answer the question.
Azathioprine will
I will
take 3 months
ask.
to act. Yes, he's right. If you are not responsive to, but if you read, mycophenolate is rather useful in those who are refractory to azathioprine. Like in myasthenia gravis, it is refractory myasthenia. Mycophenolate always score polymyositis. So azathioprine will take 3 months to act. Azathioprine, whereas MMF will take only 1.5 to 2 months, and it is more highly more efficacious than the azathioprine. Plus the liver toxicity immunosuppression is very less with the, we are more confident in using mycophenolate, that is why we were using. But yes, we can, if you think that is not responding, but this patient will not give us time to experiment with drug will respond, with drug will not. So I think it is a tough decision, but still I think we will go with mycophenolate only, because that has worked previously also, and disease has started after we stopped that. So family will be more coherent, more in line with us, and we will be more safe in starting, because in stroke you cannot take a chance. Although in polymyositis you can take a chance of weakness increase, but it will not be life threatening. But if we had a stroke of let us say basilar artery complete, then we are gone. That, so I
The-
think that is a
yeah.
very tough call.
From a tissue point of view, any mileage in biopsying one of the proximity posterior occipital arteries or even the
Sir,
superficial temporal
occipital artery
arteries?
we checked on DSA, it was normal. Extracranial
Yes,
circulation
normal.
was normal.
So that was some tissue would have been
Yes,
helpful.
you are, but I think as he was discussing that even hospital lobe, they are able to procure the biopsy, but sometimes they don't give us any result. And now steroids have gone in, so it might be possible we will not be getting the.
Yes, negative biopsy. Sorry, ambiguous equivocal findings. But the predominance of posterior circulation
That
entirely
was the
over such a
unique.
long period of time is
When you,
extremely intriguing and non-affectment of the meninges at all. Maybe, I mean, I do not know who is a stroke specialist out here. I'm not. And Dr. Sunil Gajre has got a stroke interest. Do you want to comment about it, sir? About the a very much isolated PACNS, only posterior circulation, nowhere
This
else.
is the first case I have seen. I have not seen.
Yes,
I've seen
reportable case
lot
as well.
of anterior circulation, both anterior, posterior, but
Absolutely,
isolatedly confined to posterior, even 2 years down the lane, I have not seen. So when you
absolutely.
asked us, so Mehak was working on that case. So I asked her, she was very enthusiastic. No, we will present this case. So I just
Yes,
uh,
yes,
referred to you that should we present that case? Then you gave us the.
absolutely.
Uh,
No, no,
this
it's
was what we
raising
wanted
more
to share.
questions and learning points because you also want to be seeing therapeutic dilemmas as part of the neurologist's daily practice. Uh, yes, Sri, you can carry on because I think I can just think
Yes, sir. So
Dr.
almost all the
Mahek
points we have
Virendra.
discussed.
Yes, please.
One thing is just to convey to the people, mycophenolate is always better than azathioprine when it comes to vasculitis.
Yes,
The
yes,
only exception is the patient is planning to become pregnant.
yes, yes.
So, sir has mentioned the point very clearly. It takes a much longer time to act. It has more hepatotoxicity and bone marrow suppression, and there are some polymorphisms in the TPMT which can increase the susceptibility. But mycophenolate doesn't have any of these side effects.
Absolutely.
So, MMF is always superior to azathioprine.
Yes.
And really wonderful that, as you mentioned, it's extremely atypical to selectively involve only the posterior circulation. Very interesting
On
case,
the
sir.
Yeah, on the concentric and eccentric, on the images Dr. Arora was showing us, it appeared to me that I think the posterior part of the vertebral arteries were more thickened. I know you made a distinction about the luminal structures being seen by the DSA and the vessel wall imaging showing actually the vessel structures, but I thought there was an eccentric appearance. Not that it will help the diagnosis, but on the imaging, Meg, did you want to pull up the images once more, if
Sure,
possible?
sure,
Maybe
sir.
it will show us
Moreover,
that
sir,
you.
if a vessel wall is enhancing contrast
That's all
enhancement,
we have at the moment to work on, you see, because we
contrast
don't have
enhancement is
issues
there,
of
then it indicate a more of a inflammatory, non-infective pathology.
which our biochemical parameters are not showing towards, and this is definitely, yeah. I'm not sure whether we can pursue progress, chase the imaging down to give us more diagnostic clues. And and the superior cerebral artery, which was constricted bilaterally, had resolved after the
Yes.
initial therapeutic cycle,
Yes, yes, sir.
which is
Yes,
also
sir.
very intriguing. So yeah, I mean, something is very dynamically happening. It's got to be autoimmune inflammatory then in the vessel walls that's causing all these, constrictions and then later recanalization phenomena. Yeah. Apart from this, you showed some MRIs after this on the
Yes, sir.
T2, T1, I think you showed us some. Yeah, I think these ones you magnified and you showed us some. You see, if you look at the vertebral artery, particularly on the right side, it's the lumen is not. Is it concentric or eccentric? Was the question. I didn't interrupt you as you were telling us. Yeah, that's one. For example, it's clearly one-sided, isn't it? See, what would you call? I mean, not
So
that would you
the
tell us. Give us the answer, but
yeah.
just a thought.
So the enhancement is actually concentric, but it's an asymmetrical enhancement.
Asymmetric. Okay,
Yeah,
asymmetric.
in atherosclerosis, you will just find an eccentric area of wall thickening and an eccentric contrast enhancement pattern. Here,
Okay.
we can see that it is a overall concentric enhancement, but yes, there is predilection to one side. But still, this seems to be concentric.
Moreover, sir, was no risk factors were there. Even
Atherosclerosis. Yeah,
think
yeah, yeah.
atherosclerotic more commonly involved the ICA part because the sharing is more, the stress is more on the, and there is even the intracranial part as well as the lower part is also involved. So it means that there is a probably diffuse disease, which is predominantly nagging and involving the,
So
and that is
what's the
the,
driver is the question, I think. It's a
I
diffuse,
think
it's
it is a
nagging,
I think it is probably
it's
vasculitis.
vasculitis.
Yes.
And it's not possible to do a catheter vessel wall biopsy,
People
so
are
that you
doing
can.
that, but in this case, we were in our center, it is not available. So, and we probably don't
So
have
the
the
question
courage,
has come up
and the
when you
patient
go
was
to Nupur Raj.
very sick to shift to a place, and it will not, I think, yield any result.
I mean, because I think there's a question about can you thrombolize the patient for the second episode in June
So
2026?
thrombolysis, yes, it is a valid, but if you read if it is a vasculitis, you can still, but there is a risk of bleed also because vessel wall
Yes.
can rupture. And secondly, patient was not in the window period, and we know that probably there is he had one stroke within 3 days. And if you see, the stroke is more confined to a pontine paramedian artery, where the
That's right.
thrombolysis will not work because it is thrombolysis also is less effective in posterior circulation vis-a-vis compared to the interior circulation.
Yeah.
And this is not a large vessel occlusion, it is a medium-sized vessel occlusion. So still,
Okay.
I think it will not work because it
Yeah.
is not fibrin-driven process, it is a inflammatory-driven process.
Yeah.
Absolutely. Yes, Mahak, you're saying something.
No, sir,
Dr.
I
Arora?
agree
Go
with
on.
sir that probably thrombolizing could have had more detrimental effects
Better.
rather than.
Yeah. What do you think we should do, Dr. Arora?
We'll let you know, sir. We are following that patient probably
No,
next time.
I'm putting Dr. Aurora on the spot because she's done so well with
She has
overall,
worked very hard and she has
very hard,
prepared, run here and there, and she managed the patient also. There
very
are
well.
other aspects also, no? She
She
managed very well.
presented the therapeutic dilemmas so very succinctly and cogently, and that we're very, very aware of the uncertainties of critical care neurology and the forefronts of neurology. Right. I'm just wondering if there's any
Thanks.
more questions from. Thank you very much for taking time and for your short CV as well. Yeah, I was just wondering if there's anybody in the audience wants to say something more because I think we are nearing 2 hours of presenting and very good discussions, which has been really full on. So I'm feeling a bit tired and fatigued, getting old. So if there's any in the audience, anybody in the audience wants to say something, you're welcome to put your hands up or put something in the chat box or just shout and we'll unmute you and you can speak.
Sir, okay, so we wanted to thank from our heart and Department of Neurology, specifically DMC, for giving this opportunity to present our.
It's our duty to serve the Indian Academy of Neurology and particularly Dr. Mehak Arora and so many that I've been privileged to meet across the country in my travels. And our chairman is very, very young as well.
Dynamic
So
person. I think he's a very
very
dynamic.
dynamic, but he is very tall as well. So, we're very lucky to have him. Yeah. So basically, we're winding down now before Dr. Sri gives us the parting. We were hoping the president would join us, as would Professor UMS, but I will ask if they have joined or not. But if not, we thank everybody, Dr. Professor Berinda, Dr. Mehak, for really educating us on all of us. There's still 15 of us. Beyond 2 hours is difficult for people to keep on. There were some business points I made about, and Dr. Sri also mentioned about the business meeting dates. You must tell us when it's right, because on 21st, we need to inform IN. That's one. There's no meetings in September IN rules there, and we hope to see a lot of you in IN Jaipur, where we might have a meeting, informal cup of tea on the flanks. Maybe a room we'll have to promote, get to network and see each other and shake hands or do namaskar in the person. Yeah, so I think I'm very grateful to Dr. Mehak Arora and Professor Berinda, my good friend, uh, to have taken all this. We really gained from it.
Thank
And
you.
thank you very much. We'd like to see you again before our terms finish in 27. So do come back. You said about short segments on interesting topics, but maybe we should do a Plex plasma exchange protocol or statement, as Dr. Sri said, for the Indian Academy of Neurology, and then maybe do some comparisons with IVIG. But that will again dilute the whole issue, I think. If we
I
do,
think IVIG will don't take, will just recommend plus Plex
yes,
only.
I
That
think, yeah,
will
yeah.
cause
Why
problem.
don't we stick to just pure plasma
And if
exchange
you
and some
include, as
indications?
I thought, if you include the blood transfusion
Other
specialist,
colleagues,
na, colleagues,
yes,
then they will, it will give us.
please
Yeah,
work on this.
I think we
It
have the
will make it.
ISH, the Indian Society of Hematology. We can probably involve them as well.
Yes,
Hematology and
Hopefully, we
blood
should.
transfusion, the national
because
body. We'll definitely work on that, sir. By
Yeah,
the
let's
time
work
we are
on it.
done with the
Otherwise,
IA and Con, we will get the
Thank you.
approval from the executive committee, the president, and we will get this ball rolling.
Thank you.
something
Thank you.
something good for the country must come out of all this, and for the patients and from health economic perspective, because I think we really can't be leaving out a very crucial treatment modality just because nobody talks about it, nobody thinks about it, and nobody looks at the evidence behind it. So we have to really push for PLEX only where it is indicated and only where it's useful, certainly cost-wise. That right. I won't keep speaking anymore. I'll let Dr. Srivartan do the last honors of thanking and doing the valedictory as it were. It's been a very, very good session, and thank you, Dr. Meha Karura, Professor Birinder, for sparing your time to educate us and for spending the hard work to present such a wonderful topic, which went very well. And 2 hours on, we still have about 13 people remaining. It clicked to 43 at the peak. Thank you.
Thank you. Thank you for
Thanks
the
to the IN Digital
opportunities.
team. Thank you. And thanks to the IN Digital team. There was Snehal ji and Asmita ji sitting it all the way through. Right. Dr. Sri, over to you, sir.
Yeah, thank you so much, Sid. That was a really wonderful session and it was really worth it. I think this is one of the longest discussions we have had as a part of the critical care neurology subsection with a lot of interesting questions and discussions. And one thing which we have all understood is the next time we have a doubt about plasmapheresis, we know whom to contact. So Dr. Birinder would be getting questions from across subsequently whenever we have any doubts related to plasmapheresis. Thank you, sir. Thank you so much for the wonderful presentation. And thank you, ma'am, for the wonderful case which you had worked up. We will we'll definitely, as mentioned, we will definitely start the work for the position paper on therapeutic plasma exchange in neurology. So that will be done. So that we will work soon. Thank you so much, sir.
Thank you. Good night. Okay.
Very
Thank
good.
Good night, sir.
Jai
Good night.
Hind. Jai Hind. Namaskar.